go. Welcome everybody to The Big Idea. My name is Dr. Jeffrey Hanna, where we look at things that are important to health. What do? We take a little bit of research that can sometimes be a little bit complicated, have a lot of different levels, and kind of break apart the big idea in plain English for two groups of people. Number one, healthcare practitioners who really need to know this information. Number two, and arguably more importantly, people who are experiencing these different kinds of issues so that they understand what's going on in their body, who to see, and what the general process is in terms of what's necessary to actually help them improve their quality of life. And today we're going to be looking at is trigeminal neuralgia, one of, if not the number one most painful condition known to humankind. So, not something we want to be dealing with or treating lightly whatsoever. But in this particular article, and I suppose a bit of a contrast to so many of the ones that I do, where they talk about different bits and pieces about how certain therapies, certain treatments are shown to help different things. This article here, it's just a little bit of a broad brush overview that taps on the surface of something profound, but that never actually gets into it. And unfortunately, I think that that's one of the major issues for a lot of people who do experience trigeminal neuralgia. What else can I do about this? So as we are getting the ball going here, as always, we'll ask you to click the like and subscribe button here for two reasons. Number one is it helps the channel grow. Thank you, it's appreciated. But number two, by helping the channel grow, it allows for this video to be found by more people who are actively looking for solutions when they are, looking for these different kinds of things. So without further ado, we're going to jump into this. This is an article, goes back to 2013. Here we go, our brief summary. I'm not reading the whole thing this time, but just a few little bits. Two different clinical entities, essential or secondary neuralgia, are associated with different pathologies. The pathways of cranial nerve 5 comprise the cervical spine, the brainstem, the root of the nerve, and the three peripheral branches. They call it V1, V2, V3. The ophthalmic division, the maxillary division, and the mandibular division of the fifth cranial nerve. The lesions responsible for neuralgia are neoplastic, which means a tumor, vascular, which refers to blood flow, inflammatory, localized swelling for any number of reasons, malformative, something weird in terms of your anatomy, or post-traumatic, results of physical injury. The examination protocol should explore the set of cranial nerve 5 pathways. Neurovascular compression is the main cause of essential neuralgia. Okay, that's nice. This is just a bit of an anatomy lesson here so far. But throughout the course of this article, they talk about and they glaze upon a few different topics that are relevant to people who, again, are experiencing issues of trigeminal neuralgia. For those of you who do not experience this, I don't wish this on anybody, not even my worst enemy. Trigeminal neuralgia, it comes in a lot of different flavors, from a relatively mild, dull toothache to the sensation that somebody is stabbing you in the eye, and most relentlessly and or somewhat random. When people experience things such as sciatica, lower back pains, things in different parts of their body, as severe as that can be, to a certain degree, you can block it out. When you're talking about disorders that affect your head, your face, whether they would be migraine, whether they would be severe kinds of cluster headaches, whether they would be dizziness, vertigo, or something such as a trigeminal neuralgia. I don't care how mentally strong you are. You're not blocking that out, is the short of it. And people are willing to do pretty much anything to find relief, even going to very drastic solutions. And unfortunately, they don't know about some of the other options that might be available, as we're actually going to showcase you in this particular article. So let's talk about a few of these things right here. So trigeminal neuralgia can be caused by a lesion of the sensory nuclei of cranial nerve 5 and the sensory root and its branches up to the skin. Exploration of the pathways of cranial nerve 5, therefore, involves analysis of the posterior fossa, back of the skull, and the facial bones. The nuclei of cranial nerve 5 had broad distribution over the brainstem and the upper cervical spine. This explains why cervical, medullary, bulbar, pons, and mesencephalic lesions can be responsible for cranial nerve 5 neuralgia. Okay, so what does this mean? Firstly, I'll draw your attention back down to this particular picture here just to show you again the different distributions of where this particular nerve goes. The trigeminal nerve, it's the principal sensory nerve of the face. Motor function of the face, with the exception of those muscles that move your jaw, is actually a completely separate nerve. The trigeminal nerve is responsible for the sensory component, anything that you feel on the face, on your lips, on your tongue, not your taste buds, but you can actually feel something on your tongue, or even if you're feeling pain or pressure with something on your eyeball. And as a very simple example here, I'll oftentimes say, if you've ever gotten hair in your eye, hair is about 0.15 millimeters in diameter. And the reason your brain knows of that is because it is innervated by the sensory nerve receptors of this trigeminal nerve. So you can appreciate that something that, even if it's very, very small, can still, if it's in the wrong spot, produce very severe and debilitating kinds of pain. So imagine that instead of the hair in your eye, that it's that sensation of something else, somewhere else, coming from somewhere else. So what they're talking about is they're saying that, the trigeminal nerve and its processing centers in the brain, that these are not small things. And what they highlight is this picture right here. Now, you probably have no idea what you're actually looking at, and that's okay. This is an MRI of the brainstem. The brainstem would be approximately this long. So if you were to find where the very base of your skull is in the back, that would correspond with this area here, which is at the very top of your neck. The base of the skull is represented basically here. And then if you were to imagine that you go another 2 finger widths higher up, that is how long this thing actually will extend. Again, the equivalent of about 3, yeah, that's 3, that's 4 finger widths right there. That's how long this is. So it refers to cervical, that is, it's in your neck. Medullary, which means it's in the medulla or lower part of the brainstem. Bulbar, slightly higher up. Pons, slightly higher up from there. And mesencephalon, ever so slightly up higher. They show also on here the little white portions. That's the area that's responsible for, again, controlling jaw movements, TMJ function. The rest of it is all a primary sensory receiver. So whether it is of around your eye, your nose, your upper palate and your upper lips, or your lower jaw going to your TMJ, all of this information is processed and goes into this exact same sensory area. And so what we're talking about when we're talking about trigeminal neuralgia is where something is affecting this. And we're going to come back to this picture because what they go ahead to talk about right now are these 2 principal categories, and they're subdivided further into type 1s, type 2s, classics, atypicals, and so forth. But again, broad brush. So the first thing that we're talking about is what they call is essential neuralgia. Essential neuralgia has a characteristic clinical presentations. It's where they have intense paroxysmal, which is usually just sudden discharges or pain flashes, which last about a second and occur in repeated bursts or several minutes. So neurovascular compression is the principal cause of essential neuralgia. In other words, you have an MRI, and what you see on that MRI that something is producing pressure. It's compressing or it's irritating one of these sensory nerves, or even that sensory processing center. Think of it to a certain degree, there's a pebble in your shoe, and as a consequence of that, you can feel it rubbing up against your foot. That's what an essential neuralgia is going to be. You look on the MRI and you say, yep, there's a pebble in your shoe, metaphorically speaking. And so depending then on which part it's actually abutting against, well, that's going to be associated with whatever symptoms you'd be experiencing. So other causes, besides a compression, you can also have a compression such as a Chiari malformation, multiple sclerosis, or a lesion of the cerebellopontine angle, which is located right down through this area here, lower part of the brainstem on the back. And that it is going to be producing stretching. So again, even if it isn't like a pebble in your shoe, anything that is actually causing, I suppose a better term, mechanical deformation. Something is irritating its overall structure, and as a consequence of that, it is producing these kinds of issues. Now, they make a little comment here, and we're going to come back to this. Some patients have a normal MRI scan, which is curious. How is it possible that you can have a pebble in your shoe, but your MRI scan is normal? Doesn't quite make sense. Well, as I said, we'll come back to that. And then they show a few pictures of different MRIs. This, I don't expect you to know heads or tails what you're looking at here, so we're not going to worry about that. Secondary neuralgia. The clinical picture is different from essential neuralgia. The pain is usually dull, continuous, with, little bursts and things where it's worse, but not with specific triggers. And it's not usually just one little spot, but it is, more widespread. It can pass through or involve multiple of these different nerve distributions. It can be on one side of the face. It can be on both sides of the face. It can shift, it can come, it can go. Oftentimes it's also associated with other head, neck, jaw pain conditions, migraine, cluster headaches, tension headaches in different combinations and different degrees as well. There are many etiologies, which means causes, and any pathology on the pathway of the fifth cranial nerve can be responsible for secondary neuralgia. They're showing a bunch more pictures here. And unfortunately, that's really about the extent as far as what they have to say about it, which means, and what they're saying is, okay, yep, people are still having issues with the trigeminal nerve, but we know that it isn't a lesion. It's not a cancer. It's not swelling. It's not a bleed. It's not an infection. It's not any of those things. So many of these people, their MRI comes up as being normal, which can be very, very challenging then from the standard medical perspective, because if there's not something that you can definitively see there, that is a sign of pathology to a certain degree, you don't know exactly what to do. If you don't see anything, there's not a surgical procedure that's going to help with that. Why? Because there's nothing that needs to be cut, inserted, fused, or made a little bit more room. So they're showing a few more pictures, blah, 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 about all of these different bits and pieces here. But then they go on ahead and they talk about treatment. Okay. So initially, treatment is medical and often effective. What do? They most prominently prescribe things such as carbamazepine, fun words. When you have trouble pronouncing these things, looking at them, it's like, okay, should we be putting them in the body? So let's start again. Carbamazepine, oxcarbazepine, gabapentin, yay me, I can do one, and lamotrigine. And these are the active chemicals here, and they have a lot of different associated brand names. What do these things all have in common? They are CNS depressants. They stop all the sensory information indiscriminately of your central nervous system. And the idea is that people are in so much pain that they're just willing to numb out everything, not just the pain. That's the byproduct of just blocking all of the rest of the sensations as much as you can. And unfortunately, what people say is it feels like when they take these different things that they're walking around like a zombie. And unfortunately is if they don't, they experience, again, still very much of this relentless kind of pain. Now, if that doesn't work, these different kinds of strong painkillers, they'll oftentimes, make a recommendation for surgery. And again, this condition is painful enough where people say, doc, whatever, I don't care what you have to do it. So 2 options here. Rhizolysis, what does that mean? It means you burn or you cauterize the nerve root or some other part of the nerve transmission pathway. Concept being is that if your brain is being bombarded with bad or painful nerve signals, kill the transmission route. So at the very least, you're not suffering an unrelenting pain. Alternatively, neurovascular decompression. If you have a pebble in your shoe, and depending on its location in the brain, you may not be able to go in and exactly burn the nerve root, or the collateral damage could be so severe that is really not going to be worth it. And so what they do instead is they put a little bit of material, Teflon, interestingly enough. The idea being is if you can't get the proverbial pebble out, that what you do is you put a little bit of slippery stuff in between, so at least it's not rubbing quite as severe. And microvascular decompressions, they find oftentimes that when you do find that there's a blood vessel that is rubbing up against one of the branches of the trigeminal nerve, works really, really well, upwards of around 90% of the time. But unfortunately, two things: about 50% of the population, it has the tendency to relapse. That is, all of the stuff ends up coming back, and it also means that still there's another 10%. That it doesn't help really at all, which is unfortunate. But overall, 90% pretty darn good as far as procedures go. And as far as brain surgeries go, I would also add relatively benign. Now, I am not a brain surgeon, but let's put it this way. This is a relatively common procedure, and so it is not experimental or where we need to do this. The odds that you're going to come out okay on the other side, pretty good. But same breath, wouldn't it be nice if we could avoid surgery and if we could avoid, even the hard medication route in the first place? So I'm going to back it up a little bit here, because so far you'll notice that I'm talking about a whole bunch of things that fall quite outside of my scope of practice for telling people, helping people with trigeminal neuralgia, because I am an upper cervical chiropractor. I am not a GP. I'm not a specialist. I am not a neurosurgeon. I'm not a neurologist. But I do understand the relationship of what happens in the upper part of the neck and how it affects brain function and nerve system health. So you'll note that when they're talking about treatment, what did they say? Drugs, surgery. They didn't really mention anything else. And you will note that when you're talking about, again, surgical procedures, a surgeon will not do anything unless they can actually see a definitive lesion. So what did we say? Two kinds of neuralgias, essential and secondary. So for people with essential neuralgia, yeah, that might be an option. But what about those people with secondary neuralgia? Or for those other people where there is signs of compression, but you can't see it on the MRI? You're experiencing all of these different things we've just described. You've had your brain scans, you've had your CT scans. Well, we weren't sure, so we tried it again. And so we tried it again. You maybe even had it with a dye contrast, the gadolinium, which I am not a fan of, and if that can be avoided, because some people, unfortunately, can have very severe reactions to the metallic dye agent. But my point being is that there's a huge percent of people where it's like, no, surgery is not an option, and yet they don't want to keep taking all of these very severe drugs in terms of that's just numbing them up, and yeah, they're alive, but they're not really living. They want to know what other kinds of options are there. And so this is oftentimes then where they come across, at some point, this particular information that we're about to share with you. Because you see, we're going to go all the way back to the very beginning of this article. So what have we been talking about? And all of these pictures that they have been showing, these are of brain scans. So they've been showing, okay, this is where you have this lesion associated with the cavernous sinus. It's one of the areas that comes out where the nerve branches are located. And then more examples where the nerve branches are located. Okay, here's a lesion that's showing up on the brain stem. So these are all of the different things that you can see, including tumors, neuroplasms, cysts, all of that sort of stuff. But what did they say all the way back here? All the way back here at this picture right here. They showed that the trigeminal nucleus is not just in the brain. It actually descends down into the upper part of the neck. So all of the focus is on treating symptoms associated with this area. We're looking for lesions in this part of the body. But here's the question. If this is all one structure, and it is, and it receives all the same sensory inputs, which it does, and it works as one functional unit, well, what about this area right here? Is it possible, perhaps, that the issue is not actually in the brain itself, but you go, not those 2 finger widths above, but those 2 finger widths right here? Could it be possible the problem's located right there? Now this opens up some other possibilities in terms of what is actually producing the neuralgia here. Because you see, things inside of your skull are going to be, yes, they do move, but relatively stationary and enclosed. When you get suddenly just below that, everything is a lot more dynamic. Things are designed to move. So this action that you would do right here, that is engaging all of the vertebrae in your neck. And in particular, it's engaging the C1 vertebra and also the C2 vertebra, which are the natural pivot points, so that you're able to nod your head up and down like this and also turn your head side to side pretty much like that. 50% of all movement in your neck comes from that very particular spot. The trade-off is that this area, in order for it to be able to move that much, it is not as strong and as stable as all of the rest of the vertebra lower down. This area is held together by muscles and ligaments that suspend in things open in space so that it is able to move like this. But it's also anchored not just on the outside, but also on the inside, guess what? Directly onto the spinal cord itself. And normally, that orientation is designed to be able to support, to protect that kind of area. However, I'd like to raise the possibility of what happens if this upper part of your neck should ever be injured, even if not broken or dislocated, because that's what they're looking on MRIs. But if the thing shifts and offsets like this, ever so slightly, a millimeter or two one way or another, guess what that can do? It means that instead of that area protecting your brainstem, it can actually exert physical tension on it. And there's the pebble in the shoe that oftentimes can be associated with producing these kinds of issues, such as a trigeminal neuralgia. There have been a number of anecdotal studies, and unfortunately not really too many grand or in-depth studies, but you find anybody who does, my particular line of work, wherever they should be in the years, or, in the years, no matter how many years they've been in practice or wherever around the world it has been, and they will tell you, it's like, oh yeah, trigeminal neuralgia is absolutely a condition where you can have other things going on, but especially for those people where everything is quote unquote normal, it's like maybe you're looking in the wrong spot. Don't look in the brain, just look that little bit wrong. Well, do look at the brain. You got to rule out the brain stuff. But if the brain is normal, now go down 2 finger widths lower, because it may be likely that you're actually going to find that that is where the ultimate issue is. Now, I do want to come back to this question right here. Some patients have a normal MRI scan, and people ask me this one quite all of the time. It's like, okay, Jeff, if these problems do exist in the upper part of the neck, you can see the upper part of the neck of this MRI. Why aren't they commenting on it? Well, it has to do with perspective, is the short of it. So most neuroradiologists, what are they looking for? They're looking for large signs of pathology. Tumors, infections, broken limbs, signs of swelling, bleeding on the brain. They're not looking for 1 to 2 millimeter misalignments. But don't misunderstand that, because they would look and say, okay, yeah, that thing is normal. Well, maybe, and you can't diagnose it per se either on, static images such as this one here. Reason for that is because we are 3-dimensional beings. You'd have to do a complete 3D reconstruction of an MRI, or you have other studies done which are either called articular X-rays or CBCT, cone beam images, where you can actually see a person's unique architecture on the inside to know, okay, well, this is what the orientation of those vertebrae in their upper neck is, and then you can have a better understanding of what is normal in that individual versus what isn't normal for that person. And so what I'm going to do here is I'm going to just do a quick little edit. I'm going to pull open something on this particular slide just so that you can see. I think this is going to be worth doing. Okay, here we go. This is what's called an amplified MRI. This is a series of MRIs that are done where you're actually looking for movement of the brain itself. And so what you'd see is that the brain is actually not a solid structure that is never moving. It actually oscillates with your breathing rhythm, with the rhythm of your heart. It's the flow of the cerebral spinal fluid around your brainstem. And have a note right there. You will actually see that the spinal cord itself moves up and down like this. Usually should move up and down a grand total of about 10 millimeters, 1 centimeter. That is the width of your finger. Should be going up and down about that much with your breathing rhythm. But relatively little in terms of the upper part of the neck, this area right here. Why does some of this matter? Well, there were a series of studies that were done back in the 70s, really is when it started, where they wanted to know, the example again of the pebble in the shoe, how much irritation does it actually take to disrupt the function of a nerve? And what they found was it takes the equivalent of 10 millimeters of mercury, which is hydrostatic pressure, like pressure of fluid. They say it's equivalent to the weight of a dime, or a 5-cent coin here in Australia. And what that will do is if you have sustained pressure, the nerve will decrease in its firing capacity by about 60% within 15 minutes. And then if you take the pressure off, it slowly then does come back to its normal function. Now, when it comes to localized issues that you can have in the neck, in the lower part of the neck, if you were to have an issue such as a disc injury or anything else that may impede the normal ability of that cord to move like that, you've got about 10 millimeters worth of give before the body cannot absorb that stress anymore, and it ends up being transferred directly into the nerve system. But the upper neck, because of how it's designed with those ligaments that normally anchor it in place, the normal margin of error there is only 3 millimeters. And they also found, in some other studies here, that 3 millimeters worth of persistent, basically narrowing or constriction in and around the nerves, well, that's actually the equivalent of being able to produce 1,500 to 2,000 millimeters of mercury. Again, it's a measure of pressure. And so what does that mean? It means that, let's go back to this thing that we said right here. We said that you can decrease a nerve's ability to fire 60% with just 10 millimeters worth of mercury. And here we are now talking about issues in the neck that could have the potential to produce 10 to 20 times. Excuse me, that's not right. 100 to 200 times as much pressure. And if you go back to some of the early pioneers in upper cervical chiropractic, what they made the contention was that a misalignment in the upper part of the neck had the potential to be significant with only 0.5 millimeter worth of displacement. And not just transitory displacement, because let's face it, the vertebrae do move anytime that you move your head like this. But we're talking about where something has shifted, but now it's gotten stuck there. And as a consequence of that, it's putting persistent pressure, persistent irritation that accumulates like unpaid compound interest for months, years, or maybe even decades. Think of it like you would like this. Imagine 0.5% of unpaid interest on a 30-year mortgage. And then 30 years later, it's like, okay, now it's time to pay the bill. And this is oftentimes the case, especially for people with the trigeminal neuralgia. They say it seemed to come relatively out of the blue. And even if you look at their MRI and the MRI looks normal, I'm willing to bet vast majority of the time you look at their neck and that's going to say a very different story. It will show signs of pressure, irritation, degenerative changes, degenerative damage, very, very common that we see in people who do experience trigeminal neuralgia, which means that whatever condition is going on in their neck, that did not just happen a few weeks ago. That happened decades ago. And very likely it's been accumulating things over a period of time. So just to finish up with the part of the conversation that we were having, it is that they were saying that half of a millimeter had the potential to, cause issues. Well, guess what? That'd be the equivalent of about 25 to 30 millimeters worth of mercury, which is double what it actually took. And most commonly, the types of misalignments that we see in our practice, again, we see them because we're looking at them from different angles. They're going to be approximately 2 millimeters in size. And what that means, in a nutshell, is that you're talking about problems as tiny as they are that are 8 times over the limit in terms of how big they should be and in terms of their potential to cause issues. And remember, if you can feel a hair in your eye, and that's only 0.15 mils, and now we're talking about misalignments that are 2 mils, something that's over 10 times bigger than that, yes, even this might be very, very small, and you don't see it from the normal MRIs because you're just not looking at the right angles. You can definitely see it, but you got to look from the right angles. That's oftentimes how and why so many of these different things can unfortunately go diagnosed or undiagnosed, and why unfortunately so many people don't realize that they may actually have an issue in their neck that is actually responsible for their neuralgia. And so what do? We come back to this particular part of the presentation again, going back to this picture and to the nature of this article. This is a very good and a very well-written article, in my opinion. It gives a really good generic overview of the different components of trigeminal neuralgia. But what I like to highlight in it, and this was kind of the whole point, is that even though they mention it and they say, yes, this can be involved, unfortunately, they don't elaborate on it very much at all. And then when it comes to, what are the different treatment options, nothing is really mentioned whatsoever. This was many years ago now, but I was actually invited to speak to a trigeminal neuralgia support group. And they were all very familiar. For people with no medical training whatsoever, they could tell me all about the exact course of the ophthalmic division and the maxillary division and the mandibular division of the trigeminal nerves, and they understood where its synapses at the different ganglion. They could tell me where they had found certain lesions and what blood vessel was involved with that. But when I said to them, did you guys realize that the central processing hub of all of those branches is in your brainstem and it's in the upper part of your neck? Not a single person actually knew that. And they didn't realize that their neck could be one of the components in terms of what was actually going on. So again, if and when people ever need the neurovascular decompression, because if you've got something that's pressing up on the inside there, you probably will need that addressed. And guess what? It's probably going to help. It's going to work. But remember again that there's a huge amount of people who experience trigeminal neuralgia. There is no discernible lesion on their MRI, which means surgery for them is not an option. What's a surgeon going to do? There's nothing to do surgery on. But these people also don't want to be, doped up and turned into zombies all day. And not saying that, it means that, there's always a problem in the neck, because that's not necessarily true either. But it does mean, and this is the whole point, what I'd like to emphasize and like to leave you guys with, is that if and where you are dealing with issues of trigeminal neuralgia, if you haven't done so, do be sure that you are not excluding this area right here, which is a very, very important area when it comes to not just a potential risk factor or contributing factor, but also a solution to being helped with those different kinds of things with the neuralgia. What have I pulled open from here? This is a website which is called Upper Cervical Advocates. And this is the story of James and Rhonda Tomasi. I think that this video would have been done the better part of around 20 years ago here now. And James Tomasi, he passed away, it was 1 or 2 years ago, I think relatively recently. But in brief, he wrote a book called What Time Tuesday. And it was the story of his life and basically what changed it. You see, he'd been suffering the severe kind of trigeminal neuralgia for the better part of around 15 years, to the point where he had decided he had had quite enough and was ready to end his life. His wife recommended then that he go see somebody called an upper cervical chiropractor. By chance, on the exact day, she didn't know this, but on the day that he was planning on ending his life, and he was planning on doing it, I think it was like at 6 p.m. on a Tuesday. And she said, "I've made an appointment for you on Tuesday." And he said, "Well, what time Tuesday?" That's the name of the title there. And needless to say, he had a most remarkable healing response, so much so that he wrote a little book on it, and also shared his story and experience, which I think for a great many people over decades, it was his story who really gave hope and also healing for a lot of people, where they would then go find upper cervical chiropractors, again, such as myself here, and they would finally get the relief that they were actually looking for. So I share this again, even though the website may not have been updated in a few years, it's still active. Obviously, here, all of the same resources are still there. And it is worth going past to make sure that the legacy that, he spent so many years in terms of sharing his story so that this information would be available to help other people going forward. I think that it's important to, give him and his wife great credit first and foremost, but also to make sure that just because he may have passed on, that his work and his legacy does not end up going with him. So I recommend going to uppercervicaladvocates.com if you want to find a little bit more just general information about some of the things that we've been talking about. Now, if or where you have been dealing with trigeminal neuralgia, either yourself, family member, okay, what I'd also recommend that you do is you would go to blairchiropractic.com, where you're going to find a directory of different Blair upper cervical docs from around the globe who might be able to help you out. I'm in North Lakes, which is in North Brisbane here. And so certainly, if and where you are, looking or just want to have a little chat about things to see if there's anything we could do to help, would like more information, please don't hesitate to reach out to us. You find us at atlashealth.com.au, and you've got all of the different, information on our website there, plus blog articles, links to more videos just like this. So thank you guys for watching. Hope that you have enjoyed this video, and as always, hope that it's giving you not just hope, but also a direction for things that you can do in the future. So as we always, rounding it up here, asking 3 things from you. Number 1, if you haven't already done so, hit that like and subscribe button so that you're getting our updates if and when we're posting new videos like this one, but also so that it's going to help the channel so that, again, people who are experiencing these kinds of issues can find this kind of information. Number 2 is if you have friends and family members who would be interested and who need to know this kind of information, please share this video, this link with them, because it's only by sharing this kind of knowledge that can actually make any difference. And lastly, as we said, number 3 is if you'd like more information and also, have a little bit of a chat so that, I can answer any questions you might have, get in touch with us. We're at atlashealth.com.au, located in North Lakes, Brisbane. So thank you guys all very much. We'll see you the next time. Take care then. Until then, bye-bye.